So, mediastinum is a region in the chest between the pleural cavities that contain heart and other thoracic visceral structure except uh, lung. The lateral boundary of mediastinum is parietal pleura, anteriorly sternum, posterior vertebral column and paravertebral gutters, and superiorly thoracic inlet, and inferiorly is the diaphragm. Here you can see the diaphragmatic representation of the anterior, middle, and posterior mediastinum. Anterior mediastinum is everything lying forward of the superior to the heart shadows, and the boundaries are sternum, first rib, imaginary curved line following the anterior heart border, and the brachiocephalic vessels from the diaphragm to the thoracic inlet. The thymus, it contains thymic gland, sternal extension of the thyroid and parathyroid gland, and lymphatic. Middle mediastinum is dorsal to the anterior mediastinum, extends from the lower edge of the sternum along the diaphragm and then the cephalad along the posterior heart border and the posterior wall of the trachea. And the contents include the heart pericardium, aortic arch and its major branches, innominate veins, superior vena cava, pulmonary arteries, and hilar trachea, group of lymph nodes, phrenic, and the upper vagus. Posterior mediastinum occupies the space between the back of the heart and the trachea and the front of the posterior ribs and the paravertebral gutter. It extends from the diaphragm cephalad to the first rib. Contents are esophagus, descending aorta, azygos and hemizygous vein, paravertebral lymph nodes, thoracic duct, and lower portion of the vagus nerve and the sympathetic chain. Superior mediastinum is the portion of the interpleural space which lies between the manubrium sterni in front and the upper thoracic vertebra behind. It is bounded below by a slightly oblique plane passing backwards from the junction of the manubrium and the body of the sternum to the lower part of the body of the fourth thoracic vertebra, and laterally by the pleura. So, differential diagnosis of mediastinal masses include the anterior superior mediastinum, include the thymic tumor, lymphomas, germ cell tumor, endocrine tumor, and the mesenchymal tumor. So, if a patient presents with a chest pain and investigation shows a 3 centimeter mediastinal mass in a female of middle age, then the differential would be thymoma, germ cell tumor, lymphoma, thyroid and parathyroid masses. So one has to take the history and do the physical examination, focus on the symptoms and exams finding associated with myasthenia gravis, including the ocular muscle weakness, diplopia, muscle weakness, blurred vision, dysphonia, dysphagia, progressive generalized weakness, and 15 to 30 patients of myasthenia gravis have a thymoma, and one need to ask for the history of fever, night sweat, chills, malaise consistent with lymphoma or germ cell tumor. Also, we have to listen for the stridor indicative of the airway compression and the decreased breath sound, and the pericardial rib indicative of the pleural effusion or pericardial involvement. And one has to take the detailed past medical history, include prior malignancies, smoking history, prior chest surgery or radiation, and history of cardiopulmonary disease and details of significant comorbidities. Be aware of other autoimmune disorders, including the thymoma, including SLE, pure red cell aplasia, pure white cell aplasia, and a hypogammaglobulinemia. So one can investigate with the CT scan, and location of the mass is ascertained, and the neighboring structures such as vessel, pericardium, and phrenic nerve should be seen, and whether it appears encapsulated or invasive, and review the scan for evidence of metastatic disease, including the pleural effusion and pleural nodularity, mediastinal adenopathy, and the thymomas classically present as a solid mass with lobulation, and germ cell tumor are rounded without lobulation, and they may be calcified. And prior to any thought of the invasive procedure, the serum markers should be ordered, and beta human chorionic gonadotropin, alpha fetoprotein, and the lactate dehydrogenase are elevated with non-centimeters germ cell tumors. but often normal in most seminomatous germ cell tumors as well as thymomas and lymphomas. Notably, one-third of the seminomas produce beta-HCG, but none make AFP. CT-guided core needle biopsy allows a definitive tissue diagnosis that will help to identify the tumors that are not primarily treated by surgery, lymphomas and malignant germ cell tumors. And there is a diagnosis is still indeterminate. You should consider the additional measures, including the anterior mediastinoscopy, Chamberlain procedure, video-assisted thoracoscopic surgery, or mediastinoscopy for biopsy. If the clinical setting characteristics of the mass points to obvious etiology, then you might be justified in foregoing biopsy. For the potential, it's hazardous. If the patient has ocular weakness and dyspnea and mass shows a lobulated calcification and beta-HCG and AFP are normal, then we need to investigate and see if there is suspicion of myasthenia gravis. Neurology consultation should be obtained in testing and confirming the diagnosis, and including the serological studies and repetitive nerve stimulation and single fiber electromyography. The CT characteristics are typical of thymoma, and neurological evaluation for the seropositive myasthenia gravis. One need to ask for needle biopsy and to make an operative plan, and the cardiac symptoms or comorbidities might be necessitate an echo and a stress test in the older patient with an isolated mass or who is diabetic with history of angina should clearly undergo an echo, stress testing, and ECG. And pulmonary function test is helpful in predicting post-operative respiratory issues, although the key would be the helpful for the presence of active myasthenia gravis. So the middle mediastinum shows lymphomas, cyst, mesenchymal tumors, tracheal tumors, cardiac and pericardial tumors, vascular tumors, and lymphadenopathy. The posterior mediastinum shows lymphoma, neurogenic tumors, mesenchymal tumors, esophageal tumors, hiatal hernia, thoracic duct cyst, and meningocele. Thymomas originate from epithelial thymic cells. 4% of them consist of pure population of the epithelial cells. Most have a mixed population of the lymphoid cells to a varying extent. 50% are asymptomatic and discovered incidentally on chest X-ray or at the autopsy, and 30% of the local symptoms related to the pressure or the local invasion of the SVC, cough, chest pain, dysphonia, and dysphagia, and 20 to 70% associated with autoimmune disease, myasthenia gravis, pure cell aplasia, polymyositis, and hypogammaglobulinemia. So, Masaoka classification shows stage 1 encapsulated tumor with no gross microscopic invasion. Treatment is complete surgical resection. Stage 2 is macroscopic invasion of the mediastinal fat or pleura with microscopic invasion into the capsule. Treatment is complete surgical excision and postoperative radiotherapy to decrease the incidence of local recurrence. Stage 3 is microscopic invasion of the pericardium, great vessels, or lung. Treatment is complete surgical excision and a postoperative radiotherapy to decrease the incidence of the local recurrence. Stage 4A is pleural or pericardial or mediastinal spread. Treatment is surgical debulking, radiotherapy, or chemotherapy. Stage 4B, lymphogenous or hematogenous metastasis. Treatment is surgical debulking, radiotherapy, and chemotherapy. Diagnosis is by biopsy if the patient present with atypical features or found to have invasive tumors. The limited anterior mediastinotomy Chamberlain approach is the standard approach that typically is performed over the projection of the tumor. Chest CT is the imaging procedure of choice in patient with myasthenia gravis. And benign tumors and non-invasive tumors are encapsulated The malignant tumors are defined by local invasion into the thymic capsule. The Masaoka staging system of Thymomas are most commonly used, and with the preponderance of the evidence indicates that all Thymomas except completely encapsulated stage 1 tumors benefit from adjuvant radiotherapy. The prognosis of a person with Thymoma is based on the tumor's cross characteristics at the operation, not at the histological appearance. So, the surgical techniques include the open median sternotomy or video-assisted thoracoscopic surgery. The preferred approach is median sternotomy, providing adequate exposure to the mediastinal structures and allowing the complete removal of thymus. So, in such surgery, the goal is to explore stage and total thymectomy surrounding fat and identifying the phrenic nerves. Patient is intubated, ventilated, and full median sternotomy is performed to expose and explore the thymus, identify the extent of disease, open the pleura bilaterally to assess for the lung metastasis, and to identify the location of both phrenic nerve. Free up the right inferior horn of the thymus, then free up the right superior horn of the thymus, dissect the thymic thyroid ligament, ligate the lateral vessels coming from the mammary, and make 1 centimeter incision above the right phrenic nerve onto the mediastinal pleura and remove the superficial pleura and fat with the thymus. And repeat these steps on the left side. Divide the venous branches draining into the innominate vein. Carefully dissect both superior horn of the gland into the neck and divide the small arterial branches from the inferior thyroid arteries. And in post-operative period, patient may present with a generalized weakness and respiratory distress, and one has to do a daily spirometry to track the patient's strength and identify the exacerbation of myasthenia gravis. And these patients require re-intubation if there are myasthenic symptoms. And most thymectomy patients are extubated within 6 hours, and this includes myasthenic patient. Plasmapheresis may be required for myasthenia gravis patient exhibiting ocular weakness, respiratory weakness, and although the patient warrants these sort of patients warrants immediate reintubation, plasmapheresis, and that can be initiated. If the diagnosis is less clear, then CT guided biopsy can be performed, and if the patients are inoperable, then radiotherapy should be warranted. If there is invasive carcinoma and that is involving the vessels or innominate vein, then it is safe to resect and remove in block with thymus, and it is not uncommon that major venous structures are involved, and if the tissues is fibrotic, then you are not ready to commit the venous resection, then send a saving frozen section. If it comes back positive, then proceed with the resection. If negative, then leave the clips and area for postoperative radiotherapy, and the venous resection comes in several varieties. It could be a limited resection of the inferior portion of the innominate or less than 50% of superior vena cava. SVC diameter is required, then the resection with the primary reconstruction is performed. The larger areas of the resection where the primary closure appears to reduce the flow and may be approached by the saphenous vein patch. Thus, the lugs have been prepped circumferentially and there is any suspicion based on CT. Alternatively, the bovine pericardium can be used as a patch. If the tumor invades the lung, then the patient must undergo the debulking following the chemoadjuvant radiotherapy, and tissue that is reasonable to resect should be removed in block, and a portion of the lung should be wedged with surgical stapler, and that can be done via sternotomy. The pericardium should additionally be resected with a negative margin, and if the tumor invades the heart or great vessels, the tumor should be debulked and remove the tissue surrounding the involved structures. Clips should be placed to guide the radiotherapy postoperatively. A clamshell incision is another alternative approach if preoperatively it is clear that the tumor involved the right or the left pulmonary hilum. Be prepared for the possibility of the pneumonectomy or sleeve resection and perform the appropriate preoperative evaluation. If the patient turns out to be a lymphoma, then the anti-mediastinum is rarely requires operation. However, the dialogue with the pathologist and oncologist, there may be need for more tissue, and this can be achieved by VATS, mediastinoscopy, anterior mediastinotomy, and the treatment of these patients is with MOP regime of chemotherapy or ABVD chemotherapy, and FNAC should be avoided in this condition. If there is a germ cell tumor, then these patients should be evaluated for primary gonadal tumors. Although some instances the primary gonadal sites may be found, the management and prognosis of the gonadal cell tumors depend on the type of the gonadal cell tumor, benign teratoma, seminoma, and non-seminomatous germ cell tumors. There is an absence of obvious clinical characteristics, and the serum markers are indicative of seminomatous germ cell tumor, and a tissue diagnosis is required. A benign teratoma is usually GCT, for which surgery alone is indicated. No adjuvant chemotherapy or radiotherapy is needed. Seminomas have an excellent prognosis, and they are very chemo or radiosensitive and do not require surgery. On non-seminomatous mediastinal germ cell tumor include choriocarcinoma, embryonal carcinoma, teratoma, and mixed cellular types. Klinefelter syndrome is associated with non-seminomatous germ cell tumor. The non-seminomatous germ cell tumor have a poor prognosis, and an aggressive multimodality approach has been advocated by several groups. And this treatment involves cisplatin-based chemotherapy regime followed by the surgery. And in case of symptomatic bronchogenic cyst, a complete surgical excision should be advised, and the approach is dictated by the location and scenario of the VAT surgery. If the patient has asymptomatic mass, then the resection is recommended for children and young adults with the impact of this cyst. They can be monitored serially by CT scan or MRI. If there is evidence of change in the cyst, the patient develops symptoms, then the resection is indicated. Additionally, the patient should be educated about the challenges of the resection. The most common posterior mediastinal neoplasms are the nerve sheath tumors such as schwannoma, neurofibroma. The malignant tumors of the nerve sheath origins are indifferential but far less common. Ganglionic and paraganglionic tumors are also in the differentials. Functioning paraganglionic or pheochromocytomas may have characteristic constellation of symptoms that include hypertension, sweating, and palpitation. And this should prompt the workup, including the urine catecholamines and MIGB scanning, and the patient should be evaluated for any evidence of the neurological involvement. And MRI is the imaging modality of the choice and useful for determining the extension into the spinal canal. Schwannomas may be positive for PET, and high uptake doses are not necessarily indicate a malignant process. Complete resection is advocated for symptomatic tumors and encouraging for asymptomatic tumors unless the patient has higher surgical risk. The small tumors less than 3 centimeters are least likely to grow to become malignant. If the patient is asymptomatic and is not ideal candidate for apprehensive serial imaging is reasonable. VATS and open resection are option, and VATS is more appropriate for smaller non-invasive tumors less than 3 centimeters in size. If the surgeon is experienced with this modality, then it's good. Otherwise, the open technique involves the left posterior lateral thoracotomy. The pleura is opened around the tumor with the margin of 1 to 2 centimeters, and the neurovascular bundles is clipped and ligated. And there's an important variant of dumbbell shaped tumor which should be kept in. So coming back to the tumor, if the tumor is small and appears readily accessible, we need to perform a subtotal thymectomy with contiguous removal of the mediastinal fat. If the tumor is invasive, perform total thymectomy and clip the residual disease for radiotherapy. The adjuvant radiotherapy is completely or incompletely resected. Stage 3 or 4 thymomas is considered standard of care. The use of postoperative radiation therapy in the stage 2 thymomas has been more questionable. The thymomas are indolent tumors that may take at least 10 years to recur, and therefore short-term follow will not depict the relapses accurately. The most common chemotherapy, as we discussed, doxorubicin, cisplatin, cyclophosphamide, etoposide, and ifosfamide. A few clinical scenarios. In the case of substernal goitre, we have to start workup as anterior mediastinal mass and think of lymphoma, thymoma, germ cell tumor, substernal thyroid, and take a history and physical examination, ask about the relevant symptoms associated with each diagnostic modality possibility. As we have discussed previously, Thymoma's symptoms, as we discussed, include the weakness, blood vision, shortness of breath, worsening symptoms as the day progresses. The lymphoma symptoms include the B cell, night sweats, fever, chills, weight loss, fatigue, germ cell tumors, and would include the testicular nodules in the case of males. Thyroid symptoms include the weight loss, heat and cold intolerance, weakness, stridor, dyspnea on physical examination, and we'd like to examine the cervical and supraclavicular lymphadenopathy for the thyroid enlargement and nodules. I will check the voice quality for the hoarseness and check for other signs of Horner syndrome, and that would suggest the invasion to stellate ganglion, which is associated with thymic carcinoma. I would also perform a CT scan of the neck with IV contrast to fill the subset of labs, including the beta ECG, AFP, LDH, TSH, and thyroxine. So, when dealing with these sort of masses, the patient should have fiber optic intubation, and in case of difficulty, tracheostomy with a rigid bronchoscope is helpful, and a cervical collar incision is given, and would divide the middle thyroid vein for the exposure and confirm the location of recurrent laryngeal nerve and parathyroid gland, and mobilize the superior pole of the thyroid gland with the careful identification and preservation of the superior laryngeal nerve. After the superior and lateral mobilization, I would dissect the thyroid of the posterior sternum and deliver the gland to the cervical incision. If delivering of the substernal position is impossible from the collar incision, I would perform a partial or complete sternotomy as needed, and would leave the drain in the bed of the thyroid to reduce the fluid accumulation post-operatively. In thymomas, I would ask for the respiratory symptoms, and if the patient develops thymomatous myasthenia gravis, then neurology consult should be carried out. And in dealing with such patients, they will need a non-depolarizing muscle relaxant and short-acting paralysis so that phrenic nerve can be tested during the case if needed, and would perform median sternotomy. Both pleura would be opened and phrenic nerves identified starting quarterly, and will perform the operation as described earlier in the discussion. In any patient with preoperative myasthenia, we would cautiously resect the phrenic. If there is severe respiratory weakness, I would opt to shave off the thymomas of the phrenic nerve in order to maintain the respiratory function and give the postoperative radiation. In the patient with myasthenia gravis and no respiratory symptom, I would sacrifice the phrenic nerve if it is involved, and both the phrenic nerves are involved. I would sacrifice uh, one and spare the other. In the case of SVC or innominate or lung involvement, we would do the dissection of the appropriate vessel and lung. And in order for the tissue diagnosis, the prior biopsy would disrupt the capsule and possibly lead to intrathoracic spread of drop metastasis, and I would only consider a biopsy in germ cell tumor or lymphoma and seem likely to be strong possibilities as the treatment of those diseases are systemic and non-surgical. Adjuvant therapy is controversial. Invasive thymomas, that is stage 2 or greater thymomas, should be radiation therapy postoperatively. Increased survival is reported with the adjuvant and neoadjuvant therapy for stage 3 and 4, radiotherapy and cisplatin-based chemotherapy. Stage 1 to stage 4A, I would recommend the resection. In the case of myasthenic crisis, neurology consult and plasmapheresis is carried out, and the patients are followed for 10 years with CT scan, and in the majority there is recurrence is seen in 3 to 5 years. Aggressive surgical resection is helpful if there is recurrence, with additional chemotherapy and radiation can be used with additional resection. Coming to thymic carcinomas, again, if the patient present with the weight loss, chest pain, my differential would be a thymic carcinoma, and especially if there is involvement of the phrenic nerve and I see elevated diaphragm. The other differentials include thymoma, lymphoma, germ cell tumor, and substernal thyroid. And we'll do a detailed physical history examination and ask about the relevant symptoms associated with each diagnostic possibility. We'll obtain a CT scan, chest and IV contrast, and send a full set of labs including the beta HCG, LDH, TSH, and free thyroxine and acetylcholine receptor antibody. If I suspect thymic neoplasm or germ cell tumor, the most likely diagnosis, I would recommend a core needle biopsy. If the biopsy is non-diagnostic, then we can perform a Chamberlain procedure. And if the diagnosis comes back as thymic carcinoma, I will perform a preoperative fluoroscopy to check for diaphragmatic paralysis, sniff test. I would get the PFTs and cardiac stress test and would recommend the resection via the Chamberlain thoracotomy for exposure of the great vessels and both left and right chest. The anesthesia would be done with a double lumen endotracheal tube placed with awake fiber optic bronchoscopy, and the rigid bronchoscopy should be available. IV access would include a lower extremely large bore access, and the arterial line should be placed on the right because of the tumor compresses the left side more commonly. If the patient is plethoric and hypotensive, I would secure the airway with the endotracheal tube, and I would then turn the patient to the left side and turn the bed upside to relieve the pressure on the right heart and right ventricle, and the tumor is likely compressing the right heart. I would resuscitate with volume and add the pressors. During dissection, the phrenic nerve is involved with the tumor. Then, as we discussed, we will sacrifice the left phrenic nerve. And regarding chemo and radio, there's increased survival report with adjuvant and neoadjuvant therapy for the stage 3 and 4. With radiotherapy and cisplatin-based chemotherapy is more favorable. If the patient has myasthenia gravis, I would do a focused history and physical examination, concentrating about other neurological symptoms, respiratory symptoms like shortness of breath, recent infection, social habitus, and the history and family history of autoimmune disease in otherwise healthy young female. And my differential include the autoimmune disease such as rheumatoid arthritis, SLE, ulcerative colitis, Crohn's disease. I would recommend a full sets of lab including the rheumatoid factors, anti-Jo antibodies, anti-DS, DNA, acetylcholine receptor antibodies, chest X-ray, and tensilon test. If the tensilon test becomes positive, I'll speak to the neurological for the further management. And after MDT discussion, if the candidate is good for surgical resection, and if the patient can handle the operation safely, the short duration of symptoms, I would recommend thymectomy via sternotomy, and I would perform the preoperative CT scan in the chest because 15% of the myasthenia gravis patients have thymoma. I would perform the PFT to check for pulmonary reserve and recommend preoperative plasmapheresis if the patient has generalized symptom. If the patient has myasthenia and does not show a mass, I would give a stress dose of steroid, and if the patient on maintenance steroid, I would administer non-depolarizing agent for paralysis in case of surgery, and I would place the patient in supine position, perform sternotomy, and the pericardial fat is dissected out of the diaphragm, and the entire thymus is dissected of the pericardium and pleura, and dissection could go from 1 centimeters adjacent to the phrenic nerve to the 1 centimeter of opposite phrenic nerve. I would open the pleura to visualize the phrenic nerve entirely, and the dissection will proceed to the superior lobes, which are individually dissected and ligated without disruption of the capsule, and would recover the patient from intensive care in 24 hours, and there is the risk of the postoperative myasthenic crisis. In the case of germ cell tumor, if I'm suspecting such pathology, I would perform a thorough history and physical examination, focusing on the symptoms of lymphoma and weight loss, night sweats, fever, chills. I would also ask about the recent infection, respiratory symptoms, and the history of the family history of autoimmune disease. And I'll also recommend a full sets of labs and chest X-ray. And the differentials include germ cell tumor based on the location, patient sex, and age. In addition, we should also consider lymphomas, thymomas, substernal goitres, and obtain the CT scan of the chest with IV contrast. And we'll send a full set of blood labs, including beta HCG, AFP, LDH, TSH, and free thyroxine and acetyl choline receptor antibodies. Also examine the testicle for the possible testicular germ cells. I would also recommend a CT core biopsy, and if it is not possible, I would perform the biopsy using Chamberlain or Watt's procedure. Seminomas tends to grow slowly and are sensitive for radiotherapy. Cisplatin-based chemotherapy is used for metastatic disease, but is advocated for the first-line therapy. If after the radiation there is a residual mass, I would favor the suggest the resection, and if the markers are elevated, it's usually a non-seminimatous germ cell tumor by clinical diagnosis, then can be treated with tissue diagnosis. I would recommend chemotherapy with bleomycin, etoposide, and cisplatin. And if there is a residual mass after therapy, we would repeat the tumor markers. And if the markers are normal, we would resect the tumors, and which is almost always a mature teratoma or necrosis. If the markers remains elevated, I would recommend a chemotherapy instead of resection. If the pathology after resection for residual mass is revealed by a variable non-seminimatous tumor, I would recommend more chemotherapy. Teratomas, again, the differential remains the same as we have discussed in other condition. Will performed physical examination and focus on the B cell symptoms and the neurological symptoms. If the lesion appears to invade the surrounding structures or it's unresectable, we will perform the biopsy. Otherwise, we will proceed with median sternotomy for diagnosis and treatment. And since if the mass is large and symptomatic, uh, It's unlikely to be lymphoma and could be teratoma. In addition, the malignant germ cells tumor, it's less likely to be a woman. I would perform a sternotomy and would assess both the sides of the chest, major vessels, both the lungs, should show the resection as necessary. If there's a posterior mediastinal mass, the diagnosis is usually the neurogenic tumor, and there could be a foregut cyst, and it could be well as infectious mass. We perform focus history and physical examination and check for the B cell lymphoma symptoms. We'd also ask for headache, history of palpitation to rule out pheochromocytoma, and also ask for diarrhea, flushing, gastrointestinal symptoms, dysphagia or dynophagia, assess for the nerve involvement and paresthesia, and we do CT scan and urinary metabolites for VMA and HVMA, and serum levels of the VIP and norepinephrine. We would not biopsy the tumor if it looks unresectable and perform, if it is resectable, we will perform a VATS resection. The patient is placed on lateral decubitus position with a double lumen endotracheal tube, and 3 ports VAT is used for dissection. In the case of foraminal and spinal involvement, we'll do the open procedures. Spinal artery involvement or a very large tumors are also dealt with open procedure. If there is spinal involvement, then we'll do a neurosurgery and involve the neurosurgeons, and will perform the open resection. The posterior approach or Grillo incision is placed on the inferior border of the mass running to the vertebral edge and mid-axillary line, and thus allow the exposure for laminectomy and interspinal dissection. And the spinal dissection would be done first to avoid the traction on the spinal cord during the lateral part of the case. If the patient complains of postoperative severe headache, we'll check for quantity and quality of the CSF leak, which is and perform a CT myelogram. If there is a local invasion of the tumor, we'll perform a radical excision with a wide margin. If with the RO resection is not possible, we also mark the areas for the future radiation therapy in the clips. If the patient is hypertension, flushing, postoperative VMA, and this is likely paraganglionoma and pheochromocytoma, preoperatively we would have patient alpha blocked, beta blocked, and treat hypertension without unopposed alpha simulation, and pre-operative volume resuscitation would be given for volume depletion. We would perform an open resection because these tumors have the highest likelihood of malignancy and can be quite vascular. We would follow the patient with close monitoring of the blood pressure monthly for 1 year and then bimanually thereafter, and would also monitor clearly yearly the keratocolamine levels for 5 years. And if the malignancy recurs, will perform chemotherapy with MIBG1 therapy. So these are few important facts. Thank you very much. Hope you have enjoyed the video.